Olá, boa tarde. Bem-vindo à nossa quarta palestra do quarto dia do nosso congresso Vaccine Business 2020, com o palestrante Brian Faulkner, especialista em gestão de clínicas veterinárias, que irá apresentar a palestra Como prover anestesia e cirurgia em nível de excelência. Aproveitem!
So welcome back again and to this 7th module in the Veterinary Business Leadership Programme. In the previous module we looked at financial productivity and I listed the defensive and the offensive orientations towards driving financial productivity, but I skipped the defensive P for pricing. So let's look at the logic and the principles that I use to price each of the products and services that we can use. I categorise everything that we sell into the following categories. We have preventative healthcare, sick animal income, as well as any merchandising should your practice sell any. Sick animal income is made up of consultations, diagnostics and therapeutics. And preventative healthcare income comes from the big five of vaccines, external parasite control, internal parasite control, neutering and food. So in terms of the options I have on my price list for veterinary consultation charges, I have a C1 for a primary consultation, a C2 which is always 80% of C1, and what I call a C short. And that's what I call a non-thinking consultation. In other words, it's a consultation where I know exactly what I'm going to do before it begins, such as express anal glands, clip claws, or give a pre-prescribed medication. I also have a consultation charge called Cons Urgent or Unscheduled, and this is 20% more than the standard C1. And I use this consultation charge at my discretion should an urgent case arrive as an extra in the middle of a fully booked surgery, or should a client just walk into the surgery wanting to be seen without an appointment. In terms of lab, I charge 20% more for the same lab test if I perform it in-house, compared to the price that it would be if I sent it out to the laboratory. And that supplement reflects the value of immediacy, as well as the need to contribute towards the purchase and the maintenance of the in-house equipment that I've bought. All imagery starts at a minimum price. In my case, that's £150. In other words, the first X-ray, ultrasound, ECG, endoscopy will cost at least £150. Because imagery equipment is often the largest capital investment that most first opinion practices make, and therefore it's important that we charge a price that reflects the value of that investment. Each and every unit sold needs to contribute towards the repayment back of that purchase, as well as the maintenance of having that equipment. And we also need to charge to reflect the skill and the convenience of reading those images immediately. Therapeutics are divided into medicines, surgery, anaesthesia and hospitalisation, and fluids. In terms of marking up medicines, I make a distinction between POMV therapeutics and POMV preventatives, in other words, parasiticides in companion animal practice. In terms of the POMV therapeutics, I further categorise those into those that are used acutely or for acute medical use or chronic use. And then I divide each of these categories into whether they're administered orally or by injection. I mark up my acute oral meds by 100% and I add a dispense fee which is currently £6.50. And I mark up my acute injectables also by 100% and add an injection fee. And the injection fee is dependent on the route of administration. So for example, it's currently £8.50 for a subcutaneous injection, £9.50 for an intramuscular injection and £15.50 for an intravenous injection. I mark up chronic oral medicines by 50 or 60% and add a dispense fee which is currently £6.50. Chronic oral meds are of course the ones that we compete with the internet pharmacies. So note that I define the markup by how it's used, not by the name of the product. If you take Metacam for example, I mark the small bottles of Metacam up by 100%, but I mark the larger bottles up, which are normally used for chronic use, by 50% or 60%. I mark up acute injectables by 85% and add an injection fee according to the route of administration once again for the chronic use drugs. In the last module, I mentioned when estimating for diagnostics and surgery that I recommend building your estimate around the biggest numbers that are going to go on the bill, so we don't shave those numbers back, putting them onto the estimate first. So usually with surgical intervention, the surgical fee and the anaesthesia represents the biggest proportion of the final bill. So I'll start by adding the surgical fee, and then I'll add the anaesthetic charge to that, and I usually find this comes to about 75% of the total. Then I add the proposed diagnostics as well as hospitalisation and fluids and any post-operative charges. So surgical fees are the most commonly discounted item on invoices that vets will generate. And there's two common reasons why surgery is frequently discounted. First of all, because we simply just guesstimate how much it's going to be. And secondly, because we feel that we took longer than we should have, and therefore we discount it back to what we think the other vet might have done. I mentioned before that guesstimates are common, and often they are usually 10 to 20% less than the actual billed amount if we added each item independently. And we're particularly likely to discount surgery if we charge for it on a time basis. Because time-based billing for surgery is a difficult and a confusing mechanism for both us and our clients. So just because I'm a quicker or more experienced surgeon, should that make me cheaper than someone who takes longer and potentially puts a patient at more risk during a longer anaesthetic, not to mention the increased opportunity for infection with open wounds? It becomes very hard to estimate using time, therefore. Or should I charge even more, given that I didn't take that long just to bring my bills up in line with a slower colleague? But then if I do that, I certainly wouldn't want to be standing in court one day defending why I charged 20 minutes more than is recorded under the anaesthetic monitoring sheet. That just looks like blatant fraud and overcharging. Should other vets therefore charge less, even though they've taken 45 minutes longer than me? So I find that there's a lot of confusion between how long an operation should take and the best way to charge for it. So to get around this problem, I charge my surgery on a fixed fee basis per procedure, as opposed to basing my estimate on how long it's going to take me or a colleague that's going to do it. And this is a common mechanism in referral clinics for standard procedures. For example, if you call up a referral practice and ask them how much they'll charge for something like a TPLO, they'll give you that price pretty precisely. So I charge surgery using 5 grades of surgical procedure, categorized in terms of the skill, the time and the risk required to perform them. So here are the 5 categories. The operations included in level 1 refer to the cutaneous procedures such as stitch-ups and simple cutaneous mass removals. Grade 2 refers to most subcutaneous procedures such as lipomas or other subcutaneous mass removals. Level 3 refers to procedures which involve going inside a body cavity, such as an exploratory laparotomy. And level 4 refers to procedures which involve going inside a cavity and either inside an organ or removing an organ, such as enterotomies or even dog space. And level 5 refers to other complex procedures such as complicated fracture repairs and spinal surgery. Of course, the system isn't perfect, as this classification would include, for example, a cat castration in grade 4, which is one of the simplest and quickest operations that we do. So of course there are exceptions, but it works reasonably well as an overall skills development and charging cascade. So what that means in terms of surgical charging is that I don't charge surgery on time. I'm charging it by procedure. I also have a rule whereby I never go into a body cavity for less than a certain amount, which is currently £500. In other words, the surgical fee alone is at least £500. And a body cavity, of course, being an abdomen, a joint, a thorax, or a bone marrow. And if you're wondering why spays cost much less than this, realise that neutering is surgery that the veterinary profession discounts to the pet-owning public by 75%. We know that if we charge to spay according to the actual risk and expertise required to do it as a cavity procedure, it would come out in today's terms to £800 to £1,000. But we also know that most clients would not elect to pay this amount for a non-urgent operation, and therefore we would end up with all sorts of unwanted pregnancies, mammary cancers, pyometras, and all that debilitation that occurs with the urogenital disease that results from not being neutered. So therefore I believe as a profession we gift this to the pet owners by discounting spays and other neutering by 75%. The next item that I will add to my estimate is the anaesthetic, and I use 5 grades of anaesthetic charges that correlate with my 5 grades of surgery. So here's the table again, and at the bottom we now have a grade 1 anaesthetic, grade 2, grade 3, grade 4 and grade 5. And the charges here are correlated with the risk, the length and the depth of each particular grade of surgery. In other words, I charge different costs of anaesthetic in relation to the risk, depth and expertise required associated with the surgical procedure itself. Now this makes estimating much more efficient, as when I select the surgery from my list, the computer automatically adds the correlated anaesthetic charge. And what that also means is that I'm not charging anaesthetic by weight. The value of a general anaesthetic to a client reflects the likelihood which they believe we'll be able to navigate the risk associated with the procedure. Clients love their pets as entities as opposed to by the kilogram. Pricing anaesthesia by the kilogram is akin to a shoe shop selling a size 6 shoe at half the price of a size 12, or suggesting that I should love my children proportional to their height or their weight. I also have a principle that every anaesthetic should cost at least a certain minimal amount, which for me is currently £100. Why? Well, an anaesthetic is a risky technical procedure, and if it goes wrong, of course, consequences potentially catastrophic. Okay, we do them every day, and thank goodness complications are actually very rare. But ultimately, if you think about what we're doing with an anaesthetic, we're taking this animal to the brink of death and back again, or certainly that's what clients think. And in my opinion, that's worth at least £100 to reflect the expertise and the risk involved with the procedure. Because some practices price up anaesthetics based on the volume of the drugs that they use, and then they add a markup to that, occasionally coming out less than what many women pay to have their hair cut and coloured, or what you would get charged for a 25-mile taxi journey. But doing this totally discounts the relative risk or the expertise, as well as the nurse's time and the dedication involved in managing an anaesthetic during the unconscious state, as well as any post-operative recovery attention. So I think if you add up all that expertise and the time and the risk and the training that's required to get to that level of expertise, and compare the risk of an anaesthetic to the price that many people have to have their hair done, I have no problem charging an anaesthetic at least £100. Again, we know that many neuterings cost less than £100 altogether, but that's, as I've just said, is because we discount the entire procedure by 75%. And I will default to performing pre-anaesthetic blood testing on all dogs and cats over 8. And whilst we offer them, of course, for every anaesthetic in all patients, the client has to talk us out of us doing them when the patient is over 8 years old, as opposed to us having, for example, to talk them into it. The next costs that go onto my estimate are diagnostics. So I will frequently use and charge a radiology referral fee, say for example orthopedic x-rays. So I'll frequently send off elbow dysplasia suspects to my radiologist, and I'll get a much better report and opinion compared to my own radiology skills, where I might doubt whether that sclerotic area of that joint is significant or not. I don't pretend to be an expert specialist radiologist, and therefore the potential for missing things is reasonable. So I'll say to the client, let's send these off to my radiologist. I tend to charge a single organ ultrasound at the same price as a single radiograph. Well, that's maybe for an abdominal organ. Perhaps putting an ultrasound on a spleen or a liver, a bladder or a uterus, a gallbladder, something like that. But I'll charge the same as a single x-ray for that one organ. In other words, if I'm going to ultrasound 4 organs, it'll be the same price as if I took 4 x-rays. I also have a fixed fee for what I call a full radiology package, and at the moment that's £400. And what that means is I tell the client the most it will be £400 for the entire package. So that means that I can x-ray both limbs, all the joints with various views, and I know that I'll get the information I want without the difficulty of estimating to the client of how much that's going to be. I recommend charging for diagnostic laboratory tests at the time of prescribing them. So I don't wait for results to come back before I bill a lab result, and I do this for many reasons. First of all, clients don't like unexpected accessory charges. They prefer everything to be included so they don't have any surprises later. Or equally as badly for the business is we just don't charge these tests at all. And that can happen, for example, maybe if a patient has been euthanized before the results are back and we find it awkward to charge. Or maybe the case hasn't gone as smoothly as you anticipate and there's been a complication, and here we are asking for more costs on top of an already fraught emotional situation. I also recommend charging lab samples agreed to during consultations. Maybe a very common example of this would be the request for the urine sample during the annual vaccination, when the client mentions that their pet's drinking or urinating a little bit more. So of course we'll want a urine sample. Just on a little aside here, I find a lot of vets just want to take a dipstick and a USG. Now we could get into the technical pros and cons of whether we'd want to take a dipstick or a proper quantitative analysis, including something like a UPC. But if we do want a UPC, there's certainly cost implications to that. So if we want to do a proper UPC type analysis, I recommend that we tell the client this is what we want to do and we charge for it at the time of the booster. So I'll say to the client, I'm going to give them a pre-labeled collection container, ask them to drop the urine sample into me when they get it, having already paid for it. So that when it arrives at reception, my colleagues know which vet requested it, what tests have to be performed on it, and who the results should be directed back to. Because alternatively, we just vaguely ask for a urine sample. What happens is what I call the urine ferry arrives. And the urine ferry occurs when clients bring in urine in all sorts of shapes and sizes and volumes of containers. They hand it over to reception. And it may or may not be obvious who has asked for this sample or what they want done with it, or does it need to be charged at all. But often I find these samples that just turn up are never charged for at all. And this is particularly hard to charge, especially if the dipstick or the refractometer is actually within normal limits, because the client perceives the test of really very little value. So therefore charge it at the time of prescription. If the client doesn't want to pay for it then, well, why should we ask for the urine? And then finally, I refer to my lab as my pathologist instead of laboratory. Clients perceive the word pathologist as an expert and therefore thus offering even greater value than a much less impersonal process implied by using the word laboratory. The next section is therapeutics in terms of hospitalization and fluids. A couple of little principles I use here. I charge a day fee for in and out patients, as I call them. In other words, if a patient comes into my surgery for the day, let's say to have a lipoma removed, I'll charge a small hospitalization fee. And that reflects the fact that I've bought a kennel, I've bought and put a vet bed in it, I have to clean it, we may even have to replace that vet bed a couple of times during the day. Someone will take that patient out for a walk and for a pee, and it may even get fed. So of course there's lots of costs associated with all of that. Lots of practices I find don't charge day fee hospitalization for the in and out patient, and I think it's justifiable to do that. In terms of fluids, I charge subsequent bags of fluids as a professional fee item as opposed to just a stock item with a markup. The stock item may only cost a few pounds, and even if we mark it up, say 100%, it's still only going to be a few pounds. But I don't think that fairly reflects the effort and the attention that's required to infuse a bag of fluids. It will need nursing attention, the drip line will probably have to be unblocked a couple of times during that 6-hour period. So I have no qualms at charging that time as a professional fee, which may be even 10 times the value of the actual fluid product that's infused into the patient. In terms of charging for injections that were given during periods of hospitalization, I charge each injection as exactly the volume given. So let's say we have a series of 0.2 mils of buprenorphine. So rather than charge up, let's say 1.2 mil for 6 injections, then I will actually charge up 0.2, 0.2, 0.2, 0.2, 0.2. Why do I do that? Well, one, it accurately reflects what was actually given to the patient on the clinical notes, as opposed to having any doubt or confusion whether I actually gave 1.2 mil of a drug, which would represent an overdose. And 2, 6 injections were actually given. So therefore I think it's fair and reasonable to charge the client 6 minimal injection fees as well as the cost of the drug. Post-operative charges, I use a little acronym ABCDEF for my post-op sheet, which I give to clients. So A stands for antibiotics and analgesia. Of course, we often have to explain on the post-op sheet why antibiotics weren't given because they weren't needed. Often we've much less need for antibiotics than clients presume when we do an operation. A for analgesia and the cost associated with that. B is for bandages. If I anticipate there's going to be 2, 3 or 4 bandage changes according to the wound, I will charge them up at the time. If there's any need not to give the subsequent bandages, well, of course I can credit them back onto the client's account. But I find clients prefer to have the total expected number at the time. C refers to collars, so buster collars and the likes. D for any post-operative diets that I might prescribe and dispense. And E for the exercise recommendation. F for follow-up consultations. I charge post-op follow-up consultations at the time of surgery. Now obviously these have to be included in the estimate when I'm giving it, but I will always charge at least 2 post-op consultations for every operation except for neutering, which is a fixed-fee procedure. But sometimes there may even be 3 post-op charges, for example with the cruciate. The one that I'll do 2 or 3 days post-operation, a second one 10 to 12 days post-op, and then the one month later. So I charge them in advance so the client doesn't have to pay an extra charge after a large bill 2 or 3 days later. Plus, I don't want to have to complete another insurance claim form, say in a month's time, if I have to add 1 further consultation onto the total procedure. So I prefer to put it all there in the bill at the beginning and I charge it. And the charge of these post-op consultations is the exact same as I charge at a C2. And that also includes something like an X-ray. I find a lot of vets see post-X-ray diagnostic follow-up, but they don't charge for it. They think it's like an operation. Whereas I charge that as a genuine C2 follow-up consultation, even though I expect and hope the patient to be well. It's a consultation of time and it involves discretionary decision making, and I believe therefore it's worth charging for. In terms of pricing up preventative healthcare, well, of course, vaccinations are market sensitive to some degree, but my preferred formula is C2 consultation plus the vaccine units marked up at 100%. Ectos and endos are increasingly being combined as products. I'll mark them up by 50%. I also already discussed why neutering is 75% of genuine therapeutic surgery rates. Food traditionally has been marked up at 33% for life stage diets and 43% for therapeutic diets. But nowadays that's significantly higher than many online competitors. So you have to make a decision at really how you want to position your food. Are you providing it as a convenience for the clients that want it, or are you trying to be market competitive? And that will make a difference to the markups you decide to choose. So that covers all of the items. To finish this webinar, I want to talk about charging as well as pricing. Having a price on your price list is one thing, but charging it onto the invoice is another. So it's important to use your practice management system to provide prompts and nudges to increase the probabilities you don't forget about certain charges. So I use simple, quick macros to connect individual services that I know are going to be sold together. And these screenshots that I'm going to show you will show how quick it is to estimate and then bill up, for example, what I called a grade 3 surgical operation. So I have set the macros up such that when I charge this, it automatically prompts me to add a grade 3 anesthetic. And because I'm selling an anesthetic, it prompts me to add a pre-anesthetic blood. And I've set the default as 1, so I have to consciously opt out of not doing this. Then there's the hospitalization fee, as well as the Metacam, because I did a surgical procedure, as well as the route of the injection that was given. And next it'll prompt me as to how many post-operative consultations that I referred to that I need to charge, and I've set the default to 2. If, for example, a nurse though is seeing the patient as a post-op check, we will also charge that right here and now, and we tend to charge nurse consultations at half of the vet rate. And if you want to know much more about how to charge for nurse consultations in general, check out my colourful nurse consulting courses, as well as our non-clinical skills certificate in veterinary nurse consulting on our website. So here within a few clicks, I've created a bill of £900 approximately for a grade 3 operation. And I know by the time that I add any post-operative medicines, this final bill for a grade 3 will be around £1,000. That's of course without any specific diagnostic labs or imagery. So I like this mechanism of prompting, and I want to take a moment to show you how I use it to prompt me or remind me to ask clients about other optional services. So take for example a kennel cough vaccination, so when I'm billing up the dog booster. Not only am I using this prompt as a way of promoting the service, in other words the kennel cough vaccination, I'm also using it to ensure that I've actually asked the client whether they want or need this product. When I add the booster price to the list here, it brings up the question, do I want to add kennel cough? And this means that I need to ask the client about this service. And if the client says no, then I bill it up as a free of charge list entry that says kennel cough declined. And this item will be added to their invoice, which means that it's going to come out on their receipt. And that acts as a reminder to them that kennel cough was discussed, offered, but they declined it. And this is a much quicker and a much more consistent way to track which recommendations were given, rather than depending on the vets writing this in the clinical notes. I do the same at first vaccinations when discussing the offer of 4 weeks free insurance. And since we advertise that we give the option of 4 weeks free insurance as part of our vaccination pack, it's essential that we don't forget to discuss it. Because I've seen instances where clients have claimed that had they been offered the 4 weeks free insurance, the insurance would have covered the cost of the illness or the accident which occurred within the period. So therefore we prompt it when we're billing up the first vaccination. And if the client says no, well, we bill up a free of charge list entry onto their invoice that says 4 weeks free declined, which comes out on their receipt. Some practice use these prompts for lots of items and lots of recommendations as a quick way to record them and ensure that the client has a list of them on their receipt. So for example, recommendations of dentistry during vaccines or neutering, and on and on. By adding these recommendations as standard trackable items also in your practice management system, as opposed to freehand text in the notes, it's much easier to track how many patients then went on and had a dental, for example, within 3 months of making the recommendation on the record. So that covers pricing. In the next module, we're going to move into the profit and loss sheet and look at where the areas of profitability can be improved or they can be compromised. And I look forward to seeing you then.